Hi friends, we have talked about some examples of very common medical errors. But now I want to transition into not just what are the medical errors, but what actually causes these medical errors to happen, right? And we are going to spend a little bit time exploring the factors that contributes to these medical errors. So again, I just want to reiterate and summarize the complexity of healthcare system together with the potential for human beings that make mistakes. And that's the primary reason for these medical errors. So, understanding medical errors and the signs of patient safety can help us design systems capable of getting it right every time, can help us design systems that are able to address the complexity and build safety nets around human errors so that these things they don't result in harm to the patient. One of the things that we can think about to really do a self assessment to make sure that we are not in a situation where we are going to be more prone to harm a patient. And to do that, we need to think about I am safe. So, what is I am safe? I am safe is a little mnemonic and it goes through things that you can ask yourself. It's kind of like a self assessment. So, I for illness, are you suffering from an illness that is degrading or inhibiting your performance? You need to ask yourself, right? Followed by M. M is for medications. Are you taking any medications that might impair your judgment? S is for stress. Are you adequately managing stressors in your life? A is for alcohol. Are you using alcohol in excess? Certainly coming into work drunk or hangover, and it's going to increase your likelihood of harming somebody. F is for fatigue. Are you getting enough rest? Right? And then E is for eating. Are you maintaining a healthy diet? And it goes beyond that. Are you kind of taking care of yourself with exercise and things like that as well? And again, this is a little mnemonic that's been found that healthcare providers can do by themselves to make sure that they are performing optimally and are going to be less likely to contribute to a medical error. We talked about the fatigue issue, right? And there was a study on physician performance that found that being awake for 24 consecutive hours was basically equivalent to having a blood alcohol level of zero point 0.1, right? So that would be considered legally intoxicated by most standards. So again, this just exemplifies the importance of adequate rest and the benefits of having these work hour limitations, right? So another area we find contributes to adverse events for patients are failures or breakdowns in communication and teamwork. This is definitely another leading cause of adverse patient events. So lack of appropriate communication creates these situations again where medical errors are more likely to occur. If teams are not on the same page, if the left hand does not know what the right hand is doing, then these errors have the potential to cause severe injury and unexpected patient death. So, one of the high risk areas is times of transitions, right? Where you are handing off patient from one healthcare provider to another. This can happen at the time of sign out or when patients are being transferred, let's say from the floor to the ICU or from the ICU back to the floor, from the emergency department to the units. These are all transition areas or handoff areas where, again, if you don't communicate well, we expose the patient to potential harm. So, an example is a patient is in the ICU, they were started on heparin, and the patient then gets transferred to the floor. The heparin was supposed to be discontinued there, but it was not discontinued. It was not conveyed to the nurse on the floor. Then the patient remains on the heparin drip, and no one knows that the patient is on heparin, and they are not checking their coax. And this thing, the patient suffers some internal bleeding, right? So again, these are just one example where a simple lack of communication can really translate into major harm for the patient. right? So what the study of medical areas have done, what the study of patient safety has done is to identify techniques of structured communication that can help safeguard against these types of errors. So, one example that's been used and it's been shown to be very effective is something called S bar. So, it's another acronym or mnemonic SBAR, right? So, what does it stand for? So the S stands for situation, B stands for background, A stands for assessment, and the R stands for response. What's the required response that you're looking for, right? So, for instance, if you are calling your residence or you are attending after seeing a patient's emergency department, you start with the situation. I'm seeing a 47-year-old man who's presenting with acute abdominal pain, right? Followed by background. The pain started this morning. It was para-umbilical, then slowly migrated to the right lower quadrant. Then follows your assessment based on the physical exam findings of right lower quadrant, tendonitis positive, and there's some other sign, white count, right? Believe that the patient has acute appendicitis. And then R is your response or recommendation. So I believe the patient needs to be admitted and taken to the operating room for an appendectomy, right? So that's a very clear and structured way for you to communicate all the information that's needed to ensure the patient has good care. And that same structured communication can be used when transitioning a patient from the floor to the ICU, from the ICU back down to the regular step down units. Really, any aspect of clinical communication, if it follows that, then it's less likely that we will miss important details in the patient's story. And again, this could be safeguard against errors. This could be a safeguard to patients having errors, right? Let's talk a little bit about teamwork. You know, healthcare is a team sport, right? Again, with the complexity of healthcare now and all the specialization, it's rare that one individual physician is exclusively involved in the patient's care. And what we found is that a lack of coordination between members of the team can result in medical errors. And there's been a growing recognition of the need to improve teamwork in healthcare. And this has really led to the application of teamwork training principles. Principles that were originally developed in other industries like aviation. What we have done is we have adopted those principles from the aviation, and now we are trying to put them into a clinical setting to improve the way that healthcare team performs, right? So what are some of the recognized barriers of effective teamwork? Well, that includes inconsistency and team membership, right? So when you're having different people who are composing your team and not the same people that you are working with all the time, it's a barrier to getting a really a cohesive team structure, followed by lack of time, lack of information sharing, hierarchy. So medicine has a lot of hierarchies, right? We have the totem pole with attending on top, and sometimes the medical student on the bottom, and anyone else kind of in between. And what we find is that hierarchy is not really conducive to effective teamwork. And if you really want teams to be able to communicate well, to have input from all the members, right? So, you know, together we achieve more. My team really have to try to flatten that hierarchy so people feel comfortable communicating at different levels, and people are going to be listening to one another. And again, that's really been shown to improve safety. And there's a other long list of things here that you can take a look at, that are the barriers. And again, steps have been taken to try to address these barriers and overcome these in healthcare setting, right? So now let's talk about teamwork training. So teamwork training, these skills that we have taken from other industries, they help to make patients safe by developing effective communication skills, by creating these supportive working environments and an atmosphere where all team members they feel comfortable speaking up when they suspect a problem. So a common example or a classic example was There was a case of a student who was invited to observe a pediatric cardiac case. Chief resident asked if the student wanted to watch. Then one student got very excited and he went in the pediatric department, and he was watching them prepare the patient, and he noticed that one of the nurses inserting the Foley catheter, and he found that this does not seem to have a sterile technique. Now again, this is a student not part of the team, and he kind of low on the totem pole, if you want to use the term. He did not feel comfortable speaking up and pointing out this event, and he think kind of rationalizing themselves, well, maybe they do things different in pediatric surgery, not quite sure. Days later on, rounds the patient, develops an infection, and everyone is, trying to figure out the cause. Ultimately, they do find out that it was a urinary tract infection, and the student at that point speaks up and noted and states what they notice in terms of the insertion technique. This is a classic example of again where that hierarchy stands on. So, teamwork training helps team members cross monitor each other, right? So, kind of check each other's back. So, a perfect example that students saw that catheter not going a sterile technique, cross monitoring, checking, hey, and I noticed that there's a breach and sort of technique. You might want to, that out and place a different catheter. And effective teams offer assistance to one another when needed. And again, they address errors in a non judgmental fashion, right? That's really important to decrease that defensiveness. It's not about pointing fingers, but again, we are all on the same team trying to do the right thing for the patient, right? So, here are some things that have been found to be very effective in building that type of teamwork. Doing huddles, right? Where the team actually gets together prior to whatever a phase of care that they are doing and talking about what's the plan, right? So I actually huddle every morning with my team before my clinic. We go over the patients that we are seeing, we make sure that we have everything that we need, and again just kind of gets everyone on the same page. Briefs are also very helpful. There's moments where you can pause and kind of touch base with the team to make sure that everyone's still on the same page, especially if unexpected events starts to happen. And then debriefs, right? And this is something where, like, I think a lot of times in medicine we don't take advantage of this. But when we are done with, at the end of clinic or the end of an operation, or maybe after the end of shift in an emergency department, does a team gets together to kind of reflect on the care that was provided? Let's give each other a high five. We did everything right, or there's some ways that we could be more efficient, or we had that one problem, and here's what we thought caused it. And by doing that debriefs, we can kind of learn what works well and what we should continue doing in the future, and also what did not work so well, and discuss as a team how we can try to improve that next time. So again, these three things: huddles, briefs, and deep reasoning. This is my end of my lecture on different causes of medical errors. If you like this lecture, please do share this lecture with your friends, and do subscribe to my channel for more interesting concepts. We meet in the next lecture with a new concept. Till then, stay tuned. Have a nice day.